The next tranche of responses we were able to theme under the heading of assessing cost effectiveness. So challenges that HTA agencies perceive or were experiencing when they were trying to assess the value for money of a test or a treatment for COVID-19. We got 31 responses under this category, and the biggest of them was lack of data. And by that, I mean a lack of data sufficient to populate, to understand cost effectiveness. So generally, cost effectiveness is estimated and understood through a formal economic evaluation. It might be an economic model, it might be something that happens alongside a trial, but essentially a comparison of health outcomes alongside a comparison of the impact on costs of the new intervention. So weigh both of those things up together. And a treatment might be very effective, and if so, then health systems and HTA agencies are generally happy to pay more for it. You know, health gains should be paid for. But to get a robust estimate of cost effectiveness and understand what that trade-off is, needs a lot of input data to be synthesized in this economic evaluation. Things like, what's the impact on resource use of this intervention? Does it stop people going to intensive care? Does it require more follow-up visits? Does it require more visits to a primary care setting? What's the price of the technology? That was a really interesting one, actually. Early in the pandemic, a lot of medicines that were being either developed to treat COVID-19 or repurposed for COVID-19, their price was still not published. They didn't have list prices, or companies were perhaps quite tight-lipped about what the price is going to be. We're very rarely in a situation as an HTA agency that we're trying to take a view about a new intervention, a new medicine, and we don't know what the price is that the company is proposing to sell it to us at, sell it to the health system at. We need quality of life data, and that goes back to the previous point on assessing clinical effectiveness regarding we're interested in whether an intervention improves quality of life and extends length of life. Crucially, we'd like to see long-term outcomes. So if we don't have that data, if we don't know what the outcomes for COVID patients look like after 1 year, 2 years, 5 years, we can at least have some scientifically plausible way to extrapolate and make assumptions around that. And we'd like to have data about downstream care. So what happens after a person is discharged? Do they come back? What happens when they get, in the proportion of people that have long COVID, how frequently, what care do they receive? Because all of these things will have costs and health outcomes that kind of all merge together to give you the estimate of cost effectiveness. The problem with the more data that you lack for an economic evaluation, the more of these boxes that you can't tick means you increasingly rely on assumptions. So the person conducting that economic evaluation, the researcher or the company, will have to just make an assumption about what this technology means for quality of life, or what this intervention means for long-term outcomes. And the more assumptions that you build on top of one another in an economic evaluation, the less useful it becomes for actual decision making, because it becomes more of an exploratory exercise to just understand what different, you know, how sensitive the results might be to different assumptions. So that was a real concern when it came to assessing cost effectiveness. There was a perception that, in particularly for long-term outcomes and quality of life data, just wasn't enough yet to really understand whether treatments for COVID-19 and tests for the infection for the virus were a very good value for money or not. Now that,
and if I may,
yes, please.
Jamie, on this lack of data, and this is typically a domain where there is little use to obtain data from other countries. Here you need country-specific cost data and resource use data. You cannot extrapolate, or you cannot easily use data published in other systems, right?
Yeah, that's correct. Very, very rarely, because health systems differ so much. It's very uncommon. It's much more common to be able to generalize clinical effectiveness data, but health systems differ too much to really. Resource use in an English hospital might look entirely different to resource use in another country in Europe, to make that meaningless. Now, that lack of data also sat quite unhappily with a number of responses that we received relating to how complex assessing the cost effectiveness of COVID interventions is going to be. So there were three main reasons for this. One is that in 2021, there was still HTA agencies and the scientific community still had an incomplete understanding of the disease. And it's really hard to develop an economic evaluation, perhaps develop an economic model to characterize a disease and start understanding the value of different treatments and interventions if you don't really know how to characterize that disease effectively. And particularly, it's been mentioned a couple of times now, but relating to long COVID. So back in 2021, that was still uncertain about what that meant, what long COVID looked like, how many people got it, how it was treated. And so it's difficult to really map out an accurate pathway of the disease and schematic of the disease if the disease understanding is still changing. And also, crucially, new variants were appearing frequently, and they had slightly different nuances in terms of how infectious they were and severe they were. So the disease was changing. It wasn't just that our understanding of it was changing, the disease itself was evolving. And so it was accepted that any kind of economic evaluation will be quite complex and difficult to get off the ground. But even if you were able to do that, there were two elements that came out quite prominently in the survey responses and the discussion. And one is that for an infectious disease, if you have a test that seeks to identify people with it and advise that those people are isolated or treated, or if you have a treatment that purports to reduce transmission, then you need to capture that in your evaluation. You need to understand what disease transmission looks like, how many people get infected by somebody with the disease in the community in a hospital setting. You need to understand those transmission dynamics to understand the benefit of, if you prevent one infection, how many subsequent infections are you also preventing? Or if you correctly identify a case that then leads to isolation, how many and further infections does that prevent? So to understand the value of anything that reduces transmission or hopes to reduce transmission, you need to be able to quantify that and model it. And that's just not something that HTA agencies are routinely presented with. We're much more used to seeing an economic evaluation, a model in which there's a known patient and they receive an intervention or they receive a comparator and the disease isn't infectious and their outcomes are mapped out then. So that's an added complexity. Secondarily, there was a perception that to really understand the value of an effective treatment, particularly early in the pandemic when hospitals were full to capacity, there was a need to really quantify and model system dynamics. So if you've got a treatment that reduces the length of hospital stay by a week in a system with no capacity and all hospital beds full, that implies there are people waiting for hospital care that can't access it, that might therefore get very poor health outcomes. But if your treatment reduces length of stay, how many hospital beds does that free up? How many people are now able to access care that couldn't and achieve hopefully better health outcomes? Now these two things were kind of, I mean, that like disease transmission, system dynamics are not something that we frequently are presented with in value assessments in HTA. So these are two extra complexities that there was a perception that these would be needed to really understand the value of effective treatments. And we're not often presented with them. So there's perhaps a skills shortage within HTA organisations to really understand how this should be done correctly. And going back to the previous point, there is a lack of data. So the more complex that you need to, the more complex an analysis you need to produce, by default, the more data you need to input into it. And we were in a situation where there was a perception that the data were lacking and the complexity was higher than usual. So that was a really challenging situation on two fronts. The third sub-theme when it came to assessing cost effectiveness was, what's the appropriate analysis perspective to take? When I say analysis perspective, what I mean is, for an economic evaluation, kind of upfront, you need to ask, in this analysis, who is it that pays for the intervention of interest, and who is it that benefits from the intervention of interest? So typically, HTA organisations will take something like a healthcare perspective, quite a narrow healthcare perspective, and that implies that there is a healthcare budget, and the healthcare budget is interested in paying for health outcomes that are felt by the patient or the patient's carers, you know, those immediately related to the patient. But the pandemic had massive social consequences. You know, the schools closed, workplaces closed, there were catastrophic financial impacts to businesses. Also, the urgency of the situation in most countries, certainly a lot of countries in Europe, led to a vast increase in spending to tackle the pandemic. So the notion that healthcare budgets are fixed and we can just focus on the costs to the health system became blurry, because suddenly the fixed healthcare budget wasn't really a thing anymore, because governments were rapidly increasing and borrowing funding to throw everything they could at resolving this issue. And also the vast societal consequences of COVID-19 really called into question, you know, is it right to just focus on health outcomes and take that narrow perspective, or should we be thinking about, you know, other things in our decision making, in our cost effectiveness assessments, like the impact on getting people back to work, the impact on carers, the impact on you know, labour productivity, schools, the criminal justice system, all of these things that were vastly impacted by COVID. That kind of called into question. We had 6 responses where HTA agencies were thinking that maybe this is the shock that they needed to think quite deeply about what's the appropriate perspective, not just for assessing COVID-19 technologies, but maybe more broadly, all technologies.
Jamie, listening to you and all these challenges, both on the cost effectiveness and the clinical effectiveness, it seems like it was in fact almost impossible to analyze these technologies. I think all the challenges cumulated gives the impression that your task was really almost impossible, or the uncertainty was so large that truly it was difficult to come to a conclusion, despite, I think in the UK in particular, the unique resources that were available, for example, through clinical trials like the recovery clinical trials and other institutes which are excellent in infectious disease models and all this intelligence and all this data that could help nice. But I think it's important to hear from you that it triggered a reflection in HTA agencies on the more societal perspectives, and not just the impact on health outcomes. And we hope there will be development in this aspect.
Yeah, thank you, Francois. You're right. In 2021, it almost did seem like an impossible challenge, and I think that was reflected in the first HTA reports and evaluations were conducted by ICER, the agency in the US, and it was for remdesivir, and it was very exploratory in nature. So they didn't know the price. What they set about with their analysis, which it had lots of simplifications, lots of assumptions, and they set about explicitly to identify what a cost-effective price might look like, to help with the price negotiations, to help the payer with price negotiations. And that's a very different role for HTA. We're used to, you know, making a reimbursement decision and then passing that to the payer and saying, this is what we think should happen. Instead, that was more of a, we can try and assist this process. We recognize it's uncertain. We can't make the, you know, we can't find the answer, but we can try and understand what a cost-effective price might look like. And it's also reflected in the big HTA health technology assessment conducted by NICE of several COVID technologies at once. Didn't happen until 2022. So we just needed more time. We just kind of, health systems, I'll reflect on this later, but there's maybe a case for agencies now, the HTA community, to understand when the next healthcare emergency happens, hopefully it doesn't, but when the next pandemic happens, what should our role be? You know, how can it change? How can we break away from potentially processes that are seen as very robust, but potentially very slow? What can we do quickly to help next time? I think that was an important reflection for many organizations.